Welcome everybody to today's Payne AI Tech webinar. Payne AI Tech is the Payne Artificial Intelligence and Technology Collaboratory for Healthy Aging, an initiative funded by the National Institute on Aging. And we are happy to welcome you here today. We're very happy to have with us Dr. Philip Payne from Washington University School of Medicine as our guest speaker. Dr. Payne is the Janet and Bernard Becker Professor and founding director of the Institute of Informatics, Data Science, and Biostatistics, I2DB, at Washington University Medicine. He's also the Chief Health AI Officer for WashU Medicine and BJC Healthcare. He holds additional academic appointments as Professor of General Internal Medicine and Computer Science and Engineering. Dr. Payne received his PhD with distinction in Biomedical Informatics from Columbia University, where his research focused on using knowledge engineering and human-computer interaction design principles to improve the efficiency of multi-site clinical and translational research programs. His leadership in the informatics community has been recognized through his appointment to numerous national steering, scientific, editorial, and advisory committees, including efforts associated with the American Medical Informatics Association, AcademyHealth, the Association for Computing Machinery, the National Cancer Institute, the National Library of Medicine, and the National Center for Advancing Translational Science. We're very happy to have him with us today. I want to remind folks that we will have a chance at the end for Q&A. So if you have any questions during the talk, please feel free to use the Q&A feature, and we'll hopefully have enough time at the end to get to your questions. So with that, Philip, I'll turn it over to you. Thank you again for being with us today.
Yeah, happy to be here, and thank you for the invitation, George, and the very kind introduction. So let me go ahead and pull up my slides. You know, as George sort of described when he went through my biography, I've sort of spanned a spectrum throughout my career from what might be thought of as clinical and translational research to more applied work at the intersection of informatics, data science, and healthcare delivery, and then more recently policy-related efforts. And I'm going to try to really integrate those three themes while I talk about the current state of AI and really how that can help us to realize an aspirational goal that I think many of us have held for a while, which is to create a learning healthcare system. And the real sort of underpinning message here, if you want to sort of get to the conclusion early on, is that I think this is all about digital transformation and how we really think about the use of these technologies to fundamentally reshape processes, culture, and incentives to create that learning healthcare system. So to begin with, it would be hard to open up the scientific literature, the technical literature, or more generally just current news and not find some reference to the role of AI and how it is reshaping the environment around us. And depending on what sources you read and which authors you read, you may see extremely positive viewpoints around the role of AI. Some people call this an accelerationist viewpoint, where there is sort of an almost breathless abandon as to sort of the opportunities to improve all aspects of our work and life through the use of AI. And then at the other end of the spectrum, you can see some pretty alarmist views concerned with the ethical, legal, and social implications of AI, or some of the other sort of more catastrophic unintended consequences that may occur. I will say at the outset that I am an AI optimist, but I am going to attempt to strike a balance between those two viewpoints and really describe the role of AI in what I would sort of label as a pragmatic perspective, especially in a complex environment like health and healthcare. So one of the things right away that I think is important to recognize when we talk about the role of artificial intelligence is that while there are examples of the use of AI in healthcare delivery and in research that are quite prominent, I always call out the use of AI to enable ambient listening technologies, clinical decision support, or perhaps more advanced patient engagement tools. There are a lot of other projects involving AI that are happening behind the scenes. And many of those behind the scenes applications may be more impactful than the technologies that we spend a lot of time talking about. And this is really where we start thinking about, what are the high friction, low value tasks that take a lot of our time, whether that be in terms of data collection, curation, analysis, or the delivery of new knowledge, and automate them through the use of artificial intelligence. And this chart from Gartner sort of outlines a snapshot of the current healthcare AI environment, and really talks about the types of technologies, their use cases, and their relative importance to strategic goals. And if you take nothing else from this slide, it's that there's a lot more going on behind the scenes than perhaps we may always be aware of. Now, that sort of leads us to one fundamental question, which is when we talk about AI, what do we mean? What is really the sort of nature of artificial intelligence in medicine? So I'm going to start with this very simple infographic. And this should not be a surprise to an audience like this, but really building artificial intelligence agents that can help us in terms of automating, for example, those high friction, low value tasks. That process follows a pretty well understood pattern. In the software engineering world, we would call this a design pattern. And that design pattern almost always begins with the acquisition of some representative data set that can be used both to train an AI model and then to evaluate its performance. At which point, using any variety of methods, whether they be machine or deep learning, or certainly very popular right now, sort of large language models, we're going to build a model. And that model might be analytical in nature, which means it can predict a particular outcome given a set of input data, or it could be generative in nature, where the model produces novel or new content based upon some parameter space, often described through a prompt. When we build the model, we then deploy it and evaluate it, often with internal and external benchmarking data sets. And then we may sort of scale that model up and use it in the real world, monitor its performance, and then optimize. And then importantly, we're going to learn from that model's performance and feed that back into the beginning of this process. And the reason why I share this design pattern is that one of the key issues in using AI to drive, in particular, digital transformation in healthcare is that it is dynamic. It is not fixed in time and space. The minute we design a model and deploy it, we will modify the environment in which it's being used. That will have intended and unintended consequences. We will learn from them, and then we will repeat that process. So right away, that is very different than, say, other technologies that might be more unidirectional in nature in terms of change management and impact and refinement. Now, it is, I think, an important issue to note that there is an incredible amount of hype around the use of AI. This is a model that's probably all too familiar to this audience, which is the Gartner hype cycle. And this model in particular was produced in 2023. We are now sort of 18 months out from the sort of iteration of the hype cycle that was created, and I'm certain almost everything on this model has shifted to the right. But again, there are a lot of technologies that have greatly inflated arguments being made about their potential impact in the healthcare arena. And there will be a small number of those technologies that will navigate sort of this trough of disillusionment and ultimately get to the plateau of productivity. And therefore, there is a really important role for investigators and researchers, like many of you, to play in helping us to understand empirically which technologies demonstrate the type of impact or value that warrant moving from the left to right. It's also why, in my opinion, despite a lot of sort of consternation from the academic community when people say, well, industry is going to do all this work, if we're talking about health and healthcare, industry alone cannot evaluate and understand the impact of these technologies in a way that will allow us to learn what, again, can move from left to right in this hype cycle. Now, I'm not going to read all of this, but I do want to draw your attention to a really interesting report from the National Bureau of Economic Research. And if you've not seen this, I really encourage you to take a look. It's available freely. And this report is very powerful in that what it does is provide a comprehensive inventory of all of the different types of use cases in which AI can be applied in health and healthcare. It describes the relative value proposition of those use cases and where are those technologies in terms of their maturity and adoption, as well as sort of the cost of deploying them. So this is almost like a decoder ring, if you would, that allows you to think about, given a problem, are there technologies? How mature are they? How important will the impact be? And how costly will it be for me to deploy the technology? And I would say every project involving AI needs to begin with some assessment of the current state of the art, because there is a temptation to build new technology. And as I said before, this has been going on for a while, and this certainly is the case that many of these technologies that sort of are being used behind the scenes, as I alluded to earlier, are not as well understood as they probably should be. And this report, just to emphasize the point, includes both a review of those technologies that are applicable in the inpatient as well as in the ambulatory environment. Now, I did allude to the role of large language models, so I'm going to take a little bit deeper dive there for a moment, because people often say to me, well, large language models, that's very different than using machine learning or deep learning. It is in some ways, and in particular, how we interact with the models. But fundamentally, there is a sort of design process that follows that pattern I shared with you just a few slides ago. Because when we're building large language models, what we tend to do is take a large corpora, often of textual knowledge, although not always. We can also do this images and other types of knowledge resources. We use various approaches to recognize patterns in those knowledge resources and build a language model that helps us understand, given a context or set of parameters, what is the most likely probabilistic transition between a set of tokens, for example, words, that is going to be responsive to that prompt, query, or other question that's being posed. And this allows us to predict, if it's a text-based large language model, in this case, what an output can or should be given those input parameters. But my point with sharing this with you is sort of that language model behind the scenes is not a whole lot different than the predictive models that we would use for, say, more traditional machine or deep learning. It's really just the scale and the nature of the training data that is different. I also want to point out that while we are seeing very promising results in the healthcare domain around the use of large language models, we are by and large still using general purpose models that have been trained on sort of the public internet, the contents of sources like Wikipedia, to be sort of precise. And so my point there is that we still have not seen a proliferation of health or healthcare specific models that may be trained on domain specific content or knowledge that's not available more broadly. And I think it's reasonable to expect that even with the phenomenal performance we see with a large number of sort of current base models trained on general purpose knowledge, we will see even greater performance in health and healthcare as we start building, training, and optimizing domain specific models. And that remains a largely open question. And I called out on this slide just a few of the common large language models. There's new large language models every day. Certainly, most recently, there's been a lot of conversation about DeepSeek as an example. But the takeaway is many of these models are being produced by commercial vendors in the space. That introduces some interesting challenges, although there are also now open models that are being provided, which may provide new opportunities for us from a research and development standpoint, although they also introduce substantial computational costs. Now, I'll pause here because this is a little bit of a sort of tangent, but I often like to use this before I get into the next stage of the talk. But here's an example of a large language model output where it was not trained on sort of textual content, but in this case, image content. And now sort of the probabilistic transitions are between the pixels or other atomic elements that make up the image. And in this case, I asked DALL-E, which is a OpenAI image-based large language model, to produce a picture of a doctor diagnosing a patient with the help of AI technology. Now, fundamentally, this is pretty remarkable. Think about this. With just those words, DALL-E came up with this image. And I think we could all agree that, it's not an entirely irrational visualization of what this might look like. However, if you spend a little time studying this picture, you will notice that there are some idiosyncrasies in it. I won't call out all of them, but one of my favorites is the fact that one of the potentially healthcare providers, we're assuming because they're wearing a white coat, is actually bisected by the exam table. So why is that important? Because my takeaway from this is that while this is an impressive technology and is producing impressive results, there are still many detail-oriented aspects of the use of large language models that are not necessarily perfect or infallible, and those are the detailed areas where we need to spend more time investigating the performance envelope of these types of technologies. Ultimately, when I talk about AI and biomedicine, and I really want to emphasize this point, I believe that the current state of the art argues for a world in which we use AI to enhance human decision-making, not replace humans. And this is highly consistent with the fundamental theorem of biomedical informatics that was first published by my good friend and colleague Chuck Friedman, which is that informatics as a discipline is really about the fact that it is humans and computers working together that is superior to either working alone. And this is because humans make sense of the world around us by employing pattern recognition. My favorite example is when you walk into a room and you see a table, you don't have an encyclopedic knowledge of what every table in the world looks like. Instead, you have a set of patterns that you understand that define tables, that they might have a top and legs, and if you set something on them, it won't fall off. And in a similar way, if we can train computers to be able to apply those types of patterns, back to that sort of design process I showed you earlier, we can now have computers replicate sort of reasoning tasks in a way that is somewhat, although not entirely identical, to how humans reason about the world around us. But computers can do that faster and at a greater scale than we can. The human brain is optimized to reason on, at best, 7 plus or minus 2 pieces of information at any point in time. I always tell people that's why phone numbers are the length that they are. And computers don't have those limitations. However, those very same AI algorithms that replicate human experts and their decision-making processes are also limited because they have to be trained on data, as I alluded to before, and that introduces potentials for biases. We may not even have the right data to train them on. It can be costly or time-consuming from a computational standpoint, and we need to acknowledge that dynamic process where the performance and the environment in which the model is deployed is constantly changing. And so that leads to a fundamental takeaway here that today, AI is mostly beneficial as a function of its speed and scope, not some fundamental leap in intelligence that may exceed human beings. Now, that may not hold true in the future, and there's a lot of debate around what sort of general artificial intelligence might look like, but I'm talking about the state of the technologies that we have in front of us today. Now, I want to transition and connect the dots between what I've just introduced about AI and the learning health system. And hopefully this is not a new concept for, again, this audience. And I made reference here in this slide to a number of very interesting publications, but there have been innumerable articles, books, and other sort of publications produced about this idea that if we could instrument the care delivery system, if we could generate insights more quickly, and then we could return those insights in the right time, place, and format, we would build a system in which research and clinical practice were very much intermingled, and this would increase the pace of discovery, but also improve quality, safety, outcomes, and value of care. The simple version of this is really that every time we interact with the patient, it's an opportunity to improve the care that that patient receives, their family receives, or their community receives. And I really want to emphasize here that ultimately building the learning health system is about enabling sort of an evidence-generating medicine paradigm that requires a set of behaviors. Technology certainly enables those behaviors, but ultimately it's about the behaviors and really the incentives that underlie those behaviors that makes the learning health system possible. And I'm going to make the argument now that because of the scale and scope of the data that's produced in health and healthcare today, that creating a learning health system has finally become practical because we have AI tools that allow us to deal with all of that data. And so therefore, as you can see in the call out here, I'm going to make the case that AI provides a foundational set of capabilities that enable the implementation and operation of a learning health system, and more specifically, those behaviors where we're constantly capturing data, reasoning on it, and then using those insights to improve the work that we do. Now, I'm a visual learner, so a different way of thinking that is sort of this diagram, in which we have healthcare operations and biomedical research. They produce data. We use some combination of data science and biomedical informatics methods to analyze and gain insights from those data. Again, we may use a variety of informatics and decision and implementation science principles to be able to formulate and deliver those insights in the right time, place, and format. That ultimately becomes actionable knowledge. In turn, we may study how that knowledge changes human behavior. That's really where we use decision, implementation, science, as well as sort of digital transformation competencies. We evaluate and optimize. That ultimately produces new data about the impact of these interventions, and we repeat. And if you thought of this in sort of a biological context, you basically have an afferent process in which data and information is generated from healthcare delivery, and an efferent process in which the ensuing knowledge is used to change behaviors, and then we measure impact and learn from that. And ultimately, back to my argument for today's talk, I think this requires us to use AI to be able to make sense of the large amounts of very complex, very fast-moving, very heterogeneous data that underpins this learning health system. But to do so, we're going to have to ask and answer a couple of really important questions. First and foremost, not all tasks are suitable for our focus in building a learning health system, and certainly for the application of AI. So we have to begin with the question, is the task we're focused on the right task? Even if the task is the right task, the next question has to be, do we have the data to build, operate, evaluate, and optimize those AI tools? And even if we do have the data, we lead ourselves to the third question, which is, what's the evidence standard? How do we know if we're having the desired impact? And that, by the way, remains a very challenging problem today. And then ultimately, even if we do have the right task, the right data, and we know how to evaluate the outcomes of that particular intervention, can we actually integrate it into real-world workflow? Because as I often say to my students, you get the most elegant algorithm with the best quantitative performance in the world. But if real-world users can't adopt it in their workflows, in the environments in which they are, for example, interacting patients, it is still a failure. And so therefore, we have to address that socio-technical workflow and sort of broader real-world application set of problems that sort of define question 4 here. So let's dig into those questions in a little bit more detail. Like I said, the first question is, do we have the right task? Right? Is the problem that we're trying to solve in the learning health system using AI amenable to this type of intervention? So I'm going to actually try to illustrate this using a few research projects from our team here at WashU. So the first is actually this project that looked at patients with Alzheimer's disease-related dementia. And the goal was actually to use a unsupervised or naive clustering algorithm, and it was a unique algorithm developed here at WashU, in order to understand the subtypes of Alzheimer's disease-related dementia and how the progression happens in the real world. And the spoiler alert here is that the progression of dementia in these patients does not happen in a linear manner. There are many transition states and sort of phenotypic parameters that correlate with those transition states. And if we can understand that and classify it, we can give providers a better mechanism for prognostic reasoning when considering what types of therapies and interventions to provide to patients with Alzheimer's disease. The reason why I'm using this example is because it is a naive, unsupervised machine learning task that allows us to determine, are there patterns in the data, and are those patterns potentially useful in a clinical context? Because if we do that, we're opening up the door to the idea that we could train, again, AI tools to recognize those patterns and deliver those insights to our providers. So this is an example, so what I would describe as almost a preparatory study to the development of an AI intervention that allowed us to ascertain that there were data, in this case, in our electronic health record and registries through our Alzheimer's disease research and clinical program that lead to a reasonable conclusion that we can model and understand these disease trajectory for patients. Now, here's a similar example. In this case, looking at information that might help us to better understand what clinical factors predispose patients to postoperative risks such as hemorrhage or infection. And in these scenarios, what we've learned is that much of that data lives in clinical narrative text, not surprisingly, not in structured data in the electronic health record. And we were able to demonstrate in this study that by using basically off-the-shelf large language models, we could extract those data and reason on them in a way that would allow us to predict some of these deleterious outcomes for surgical patients. So this is another example where we used AI to find out, are there patterns in the data? Are they reproducible? And do they appear to correlate with some sort of clinical outcome whereby we could design an intervention? And the answer, again, in this study is yes. And then finally, let's shift the frame a little bit and not talk about patients, but let's talk about providers. Because some of the interventions we may want to deliver in the learning health system are about supporting our clinicians. And in this case, what we found is that by using machine learning methods applied to the log files from electronic health records, we could actually find communication patterns where individuals are being interrupted by secure messaging, right? Chat within the electronic health record while they were simultaneously entering orders, and that the probability that they would actually make a wrong patient error, right? They would give an order for the wrong patient because of the cognitive load they were experiencing was much higher when using secure messaging than when they were not using secure messaging. Now, for those of you that study sort of cognitive science, this makes a lot of sense, right? We're increasing cognitive load on providers by having multiple streams of input and information, and not surprisingly, that opens up the door to more medical error. But again, this is a case where that pattern was ascertained using machine learning methods applied in this case to the log files of the EHR. So this is yet another example of a study in which we were able to find patterns that correlated with a potentially useful intervention strategy, and therefore it's not unreasonable to assume that this is a task that's worth exploring further in this AI-enabled learning health system context. So that's a pretty positive view. So far, I gave you 3 examples where we used AI methodologies to look at the data that we have, determine that there were some interesting patterns in those data, and therefore we could use those patterns as the basis for thinking through the design of an intervention, perhaps AI-enabled, that acts upon those patterns so that we can make a change in the environment. Now, here's the thing. We might have enough data to find the pattern, but the next question is, do we have enough data to be able to train a tool that can be used at scale operationally and not just in a research context? And this leads to my second question. Do we have the right data to support and enable interventions that in turn really sort of facilitate the desired behaviors in a learning health system? So sometimes that data just does not exist in the electronic health record. And I think we all know that there are many scenarios where we need to provide supplemental data to have sufficient feature space to build AI interventions. So this is an example of a project, in this case focusing on both parents and children, where the children have autism spectrum burden. And we've actually built a registry platform to recruit those individuals, extract their data from the EHR, also gain access to genetic testing data for them, and a neurobehavioral phenotyping instrument that can be delivered over telemedicine, and integrate that in a place where we can actually do research on that data rapidly. And the key here is this is a low barrier to entry platform that allows us to combine those multiple sources of data and provide an integrated view of them so that we can actually build for example, predictive models that anticipate sort of the types of interventions and their outcomes for kids with autism. And I think what's really important about this is that this is a registry platform that's designed to interoperate with the systems that we use at the point of care. It does not require people to go and manually abstract or otherwise enter those data, but rather reduces that burden to participation so that we can get more patient data and more complete data by leveraging existing data sources, and then only interject a few specific data types that are unique to this particular disease context that are layered on top of those data. So this is an example of one way of solving sort of the data access problem. Not without cost, even with all the caveats I just gave you, but sometimes we need to build sort of these fit for purpose data assets. Now, sometimes we don't need to build a specific data asset, but rather we need to combine data across multiple sources, right? And this is about the situation where no single provider organization has all of the data that they need to be able to ask and answer this question. So here, using, in this case, a PecorNet clinical data research network that spans the bulk of sort of the Midwest, this is the Great Plains Collaborative, we were able to show that we could actually replicate the manual data abstraction processes currently used for cancer registries. And if you're familiar with cancer registry, that data is usually abstracted by medical professionals that read the chart and then enter those data into specific registry management tools. And what we were able to find is actually using, in this case, this PecorNet CDRN, we could replicate those data at a sufficiently high degree of fidelity that we could produce a dynamic and frankly much more timely version of the cancer registry, in this case by doing a federated query of all the electronic health records involved in this set of collaborating institutions in the Midwest. And I think this is a powerful argument to say, even though in some cases we may be building very bespoke data sets for the purposes of research, development, and innovation, we may not always have to do that if we can overcome the technical, legal, and other sort of ethical barriers of combining data across multiple sites. And this is where federated learning, which is really the nature of the work done here in CDRNs like the Greater Plains Collaborative, is an example of a path forward to be able to combine those data across multiple institutions, multiple sites of care, to be able to have sufficient scales of data to be able to ask and answer questions. And then just to sort of go one step further, and I've already alluded to one project where I showed how we could use large language models to extract important data from the EHR that would inform perioperative risk assessment. The real question is, how close are we as a community, for example, people involved in clinical and translational research, how close are we to being able to deploy large language models at scale and in an interoperable manner? So this is actually a study that was recently conducted involving a variety of key stakeholders across the CTSA consortium that demonstrated that actually there's a already high degree of maturity across most of our leading research institutions as to the adoption and the availability of these conventional large language models, and importantly, in a secure computing environment where we can actually use PHI with large language models, such that projects that involve the extraction of information or the summarization of information from the EHR using large language models are actually possible. So what I've given you now is a few examples of scenarios where maybe we build sort of optimized registries for certain use cases. And other cases, maybe we combine data across many different electronic health records using federated learning. Or in some cases, we adopt new technologies like secure large language models to extract and summarize more data than we've had access to in the past, all in order to make sure that we have the right data to sort of fulfill that opportunity around the use of AI to drive a learning health system. However, now I may have answered the question, do I have a task that's suitable? There's patterns of interest and I can get the data I need. I still need to figure out, how do I decide whether or not the intervention I'm deciding or I'm designing is successful? And this is where that third question about establishing adequate evidence standards becomes very front and center. And as I said earlier, this is a very hard and still very much open question. So I love this quote from a good friend and colleague, Karandeep Singh, who's the Chief Health AI Officer at UC San Diego. I usually don't read my slides, but I'm going to read this one, which is that research models are rarely implemented and implemented models are rarely researched. So think about that for a minute. The reality is today, a lot of our experience using AI in the clinical arena is driven by vendor-provided AI interventions that have not been studied, for the most part, very well. We don't really understand their performance parameters, where they're useful and where they're not. And I'm going to use an example in a moment in the electronic health record domain. In contrast, because of the barriers to take a research-grade AI agent or model and put it into real-world use, we don't often see those models that we build that are highly bespoke and maybe very high-performing being used in the real world. And so this is sort of distorting our understanding of AI because we're getting access to certain vendor-provided models that do not perform well and may cause people to question the utility or veracity of AI in the clinical decision-making arena. And then simultaneously, we have very promising models that we may build in our research laboratories that do not see the light of day. And so this is a problem I think all of us have to work on together. So here's my example, back to the idea of vendor-provided models. I think many of you are probably familiar, but there were a series of papers, this one in particular, that alluded to sort of a fundamental problem with a sepsis early warning system that had been implemented by one of the major EHR vendors in the marketplace. And the takeaway is that these models, which are meant to be sort of one size fits all, that are sort of trained on a broad population level data set, but do not have customization or optimization at the individual or local institution level, basically do not provide clinically useful input to providers. In fact, what they actually do is reduce trust in and a sort of belief in the utility of these types of models because of having high false positive or false negative rates. And as you can imagine, if you were a critical care provider and you got constant alerts about patients that may be at risk of sepsis and you find that very few of those alerts are of value, you're ultimately going to ignore them, and that would be an appropriate response. And so this paper sort of sets the stage for the question of, do we really want one-size-fits-all general purpose models, or do we need something a little bit more custom? Now you might say, okay, couldn't you just take the vendor-specific models and actually do the optimization work locally? And certainly there are sort of efforts to make that possible. But I will tell you, and this is from our own group, we took that very same early warning system, and in this case, we just deployed it in 9 of our own hospitals, all on the same EHR, with relatively similar workflow patterns and sort of overall environmental factors. And the takeaway is, even with that optimization, even with that sort of more localized deployment and all the work that went along with that, we did not see any substantial improvement in the performance of that model. So even when you brought the model local and you went above and beyond and tried to optimize it, you still didn't get the results that you needed or wanted. And I think that speaks again to the fact that the model began with something that was built to be general purpose and not necessarily task or domain specific. So if that's the case with vendor models, then the next question is, well, what about the models that we build locally? What if we are really good at testing and evaluating these models? The reality is this is a very long journey. And I put this slide up here to sort of emphasize the point that there are many steps that sort of span a spectrum from identifying the initial problem that we're trying to solve, back to my prior questions, to building the model, right? Think of that design pattern I shared with you, to validating the model with maybe local data and perhaps externally with sort of gold standard data. And that goes to sort of the data availability problems I talked about before, to actually translating that model from the research arena into the EHR, which remains extremely challenging from a technical standpoint. And then even when we do that, sort of addressing these last mile problems around workflow or socio-technical considerations. For example, we have a very promising model that we've developed here that looks at operative blood loss and would help us to be more precise in planning for surgery in terms of blood product usage. It's worked very well in a silent study using data from a data warehouse. We published on it extensively. However, when we go to deploy it in the operational EHR, there are technical barriers that mean that it doesn't always trigger when we expect it to, or sometimes the performance, just the time it takes to calculate the model output, is too long for it to be useful, sometimes a couple minutes during a clinical encounter in our perioperative clinics. And so even though the model is very performant in a research standpoint, it's not useful in a practical standpoint because it doesn't address fundamental human factors and workflow needs. And actually, I'll use a few more examples. So here you can see what happens if we sort of think about sort of the ability to test and evaluate and set those evidence standards for models. So I'm going to go back to Alzheimer's disease. In this case, this is a study that talked about the use of self-explaining neural networks as a way of predicting, again, Alzheimer's disease progression. And one of the things that we learned in this case is that having that self-explaining neural network meant that the adoptability of the model by our clinician colleagues was much higher than models that were black box. Now, this is not news to an informatics community. We've known for decades that having an explanatory facility is extremely important when we are deploying clinical decision support. And that fact doesn't go away when we are delivering AI-enabled interventions such as this. And so while it's technically very challenging, this study does show that if you sort of use modern explainable AI theories and methods and apply them to high-performing AI models that maybe previously were black boxes, we can increase the ability of clinicians to adopt and use that. And part of that's about sort of the evidence standard. What's the degree of explainability that's required for these models to sort of pass a face validity check such that our clinician experts are willing to even consider using them for decision making? Another factor, though, is, as I said before, these models have to be performant in environments where we measure success in, model output being generated in under a second or maybe even faster. And that means while we might build very sophisticated models in a research context, we will also have to figure out the human factors around performance and how we get to those numbers. And in this case, this study showed that with very, very high-performing research models, in this case for subphenotyping children with neurofibromatosis type 1, we could actually render those models able to be calculated in real time and delivered in a reasonable workflow paradigm by engaging in sort of a very structured and hierarchical approach to dimensionality reduction without losing the performance of the model. And this actually uses a knowledge anchored approach in which we sort of use knowledge graphs on top of the model, not necessarily to augment as we would normally see in RAG, but rather to be able to roll up certain features and create sort of feature sets that can be calculated more readily in a real-time operational environment. Now, finally, right task, right data, we figure out evidence standards, we've studied the models, maybe we address those human factors issues in the study context. We're still going to have to integrate that model into the real world. How do we get it back to the right time, place, and format so that it's useful? So here's an example of a study from our team, in this case focusing on nursing workflow, and this was led by my colleague Po-Yin Yen, that looked at what is going on when we use an early warning system app. So in this case, we knew that we had issues with getting concerns from our nursing workforce about potential quality and safety concerns at the point of care. And part of that was the reporting mechanisms that we had made available. So what we actually did was build an app and then evaluate, and I think there are people here that actually have some experience with this project, and understand what were those communication barriers, right? This is a largely qualitative and interview-based study, but it elucidates a lot of really important human factors around the use of a tool like this, including one that can actually help us to predict where we might have quality and safety issues at the point of care. And the reason why I bring this up is back to my sort of model in the prior few slides around sort of taking a model from conceptualization to sort of real world use. You have to start with needs assessments and really understanding the environment. And that requires rigorous research and investigation on its own before we even build the first model or when those models are first deployed. So this is an example where fundamental, and I would describe as sort of very well understood informatics theories and methods come to bear on addressing those sort of socio-technical and workflow factors. Another example here is thinking about the role of telemedicine as sort of a way to augment clinical performance for teams, bringing another set of eyes into, for example, the ICU to help with sort of critically ill patients. And the reason why I bring this up is that we have a tele-ICU program here where we use a vast array of predictive models to identify patients at risk of deterioration, to bring our care team's attention to those patients, and to provide clinical decision support. And we augment that with human beings in an EICU that basically can join those in-person teams and provide an additional set of eyes, ears, and sort of, frankly, cognitive capacities. However, the real issue here is that you have to understand the workflow and sort of the hands-off of information and the relative roles and communication needs of everybody in that environment if you're going to design that AI-driven intervention. And this is a great study by my colleague Joanna Abraham that sort of explores, again, all of those human factors and workflow issues. And then lastly, I'm going to go back to sort of that idea of looking not at patients, but at providers, and going back to the work on the analysis of log files as a means of finding potential usage patterns that correlate with medical errors or other deleterious outcomes. Here, what we see is that you could actually use large language models in order to better measure and understand sort of the complexity of usage patterns in the log file that correlate with increased cognitive load. So this is about sort of semi-automating processes that normally required very time and research-intensive observational studies, and really sort of conducting simulated or pragmatic studies of those same phenomena using the log files from the EHR. So now I want to sort of bring all these threads back together and think about this sort of intersectional space of AI and the learning health system. And I would argue that ultimately, if we want to sort of really realize this vision that I have been sort of arguing for today, we really have to be laser-like on a couple of factors. One, we need to build a fair and inclusive AI-enabled healthcare system, because this learning health system paradigm enabled by AI will not work if AI is only the purview of a very small number of well-funded or very technically sophisticated organizations. Second of all, we do need to overcome hype. And I think I've made an argument there's a lot of hype and we need to get past that and think about empiric performance. And then finally, we, especially in an audience like this, need to lean in and really think about what is the unique role that we, especially in academic health centers, can and should play in this context. So I want to start by saying that the policy climate, which I didn't spend a lot of time on in today's talk, is equally complex to all of the other issues that I alluded to. And I've been very fortunate to be part of a National Academy of Medicine Commission focusing on building an AI code of conduct for health and healthcare. We've actually produced a set of guidelines for expected best practices and behaviors for people designing, applying, evaluating, and using AI in health and healthcare. And if you are interested in these topics, I really encourage you to take a look at some of these publications. Here is one of our initial publications that sort of outlines sort of the core principles that make up sort of such a code of conduct. And I want to point out this was produced not just by academics, by people from healthcare provider organizations, industry, as well as government and regulators. And I think it represents a very broad-based view of sort of the fundamental ethical and legal questions that we need to tackle. And importantly, a recent publication this group generated, which is in Health Affairs, goes so far as to outline a research agenda of the fundamental work that we all need to do together to really sort of address this intersectional space of policies, practice, and AI adoption, particularly in a very data-intensive domain like the learning health system that I'm arguing for. Second of all, I think we need to be very, very careful to overcome hype. So this is a little bit of a parlor trick, but bear with me. I entered into ChatGPT 4.0, one of the more sophisticated models available publicly, the following question. List the most important academic papers that Philip Payne at Washington University has written. I know it's a very egocentric question, but you'll understand why in a moment. And here you see the response from GPT 4.0, right? And there's a list of 5 sort of critical papers. Now, here's the spoiler alert. Not a single one of these is a real paper. They're actually all not unreasonable titles. And if you sort of get behind the scenes and think about some of the references that it uses, ChatGPT is really synthesizing a set of themes that sort of span multiple publications and grants in my own sort of CV. But the takeaway is like, this is not accurate. And some people might say, okay, that's a hallucination. See, we can't trust AI. But I would argue we need to understand why this is happening. And in fact, there is value to this because you could almost look at this as a hypothesis generating exercise in terms of papers maybe I should have written or could write in the future. So this is where sort of hype and reality sort of really sort of collide with each other. But I think we need to be quite thoughtful about how we navigate that collision. And then finally, and this goes to the unique role, especially of researchers and innovators in the field, what is our role? Is industry going to do all this work, or do we have a critical sort of part of the AI ecosystem that we really need to lean in and own? So I'm going to say, without a doubt, there is a unique and really important role for us. So first, I would draw your attention to this great paper by Chris Longhurst and colleagues about the idea that we need to start building implementation science centers that are really focused on addressing especially some of those final mile problems that I talked about. Because we as academics and healthcare provider organizations, we live in the real world living laboratory in which these technologies have to be deployed and evaluated. This cannot be done in an abstract manner. And it's really only through our deep understanding of the clinical and workflow context, evaluation best practices, and also our technical expertise in sort of the design and implementation of these models that the types of pragmatic studies necessary to understand what makes for successful implementation and what makes for failure is actually possible. I'd also say that we have to build the leadership and operating structures that makes that type of research and practice possible. And this is a paper published by a group of individuals, myself included, spanning a number of academic health centers, where we sort of made the argument that there are a number of critical aspects, including leadership, including an investment in this research capability, including sort of deep interactions between informatics innovators and IT practitioners, and most importantly, sort of embracing a co-design approach with sort of stakeholders and operational and clinical end users to make sure these technologies actually address real-world problems with impact and purpose. So with that, I will just say it would be not entirely honest of me if I took credit for everything I showed you. I'm very fortunate to have a great lab of people here at WashU that I work with. There's a picture of a few of them here, and I've also acknowledged a number of other key collaborators across WashU and externally, and not to mention all the funders that generously support the work that I've described to you. So again, this is, if nothing else, a team sport, which I think is definitional to our field in informatics and data science. My communications team made this slide, so I will say it's a little bit self-promotional, but If you want to learn more about the work that we're doing here at WashU and at BJC as it relates to all of the different projects that I sort of gave you snapshots of, take a look. You can certainly find us on the web, but you can also find us on most major social channels. Just search for WashU Informatics, Data Science, and Biostatistics, and we'll be there. And then I actually post quite a bit around sort of various papers, research developments, et cetera, on LinkedIn as well, if you want to follow any of those sort of examples. So no pressure. You can also just use good old-fashioned email and contact me if you have a question after this talk, and I'm always happy to expand on any of the themes that I alluded to today. And so with that, I just want to say again, I really appreciate the invitation to be here. I'm obviously excited about this topic, and I'm also pleased that we have a few minutes, hopefully, for some good question and answer. So I am going to stop sharing so I can see you all. And hopefully George is going to help me stay on track with some of the Q&A.
Absolutely. Thank you so much for this really great presentation. I know it generated a lot of questions. However, if folks have further questions, please feel free to use the Q&A feature, and we'll try to get to as many as we can in the remaining time. I'll start with the first one that talks about paper in JAMA AI that had a study that showed that physicians with AI versus physicians alone improved diagnostic accuracy modestly. However, when they eliminated the physicians and only used AI, the diagnostic accuracy drastically improved to about 90%, which would seem to support eliminating physicians in favor of AI alone. And so Cheryl, who posted that question, asked if you had thoughts about not just this study, but in general, the role of physician in the loop.
Yeah, so I think it's a great question. We should have done a whole talk on this. So I think it's very complicated. So I think that study is a well-formulated study, and I think it's very interesting. But I will also say that the study deals with a set of diagnostic reasoning sort of use cases that are relatively well prescribed, in which the data is available to train the models, and that sort of there is a sort of clear definition of sort of an empiric, as I would describe it, sort of right or wrong answer to the diagnostic problem. Unfortunately, that is not always the case in medicine, right? We often have missing data. We often have multiple co-occurring conditions. There's often not a clear-cut evidence standard. And so I think what we're really starting to steer towards is a world in which some of these more well-defined problems could be automated through AI, which would then free up time for the human clinicians to engage in that space where they have a unique cognitive ability to deal with incomplete and fuzzy data. So in some ways, I feel like that's an extension of my it's humans and computers working together that's superior to either alone. And I would argue that's not sort of a global statement, but rather there might be some of these tasks that we can take off the plate of our human clinicians because they can be fully automated with adequate diagnostic accuracy so that the humans can spend more time on these more complicated questions where the computers may not be able to exhibit that degree. And, you know, one of my favorite examples is certainly in the imaging space. And we have a lot of work in digital path as well as in sort of radiology. It is certainly the case that there are some fundamental diagnostic tasks that can almost be fully automated today with higher accuracy than having a pathologist or a radiologist look at those slides or images. But what that really does for us is free up those professionals to look at those really complex images and help us with diagnostic reasoning where it's not as clear cut. So I think that's sort of an extension of that AI human interaction. I think, though, we have to be very careful. You know, things that work well in the lab, and this has been my experience, don't always work well in the real world where things get very messy and very complicated. And I'm a big believer in like leaning in and just sort of embracing that mess that is sort of real medicine. I didn't talk a lot about it, but one of my sort of goals in my own lab is we don't build predictive models based on highly curated data sets. We just use raw, messy data from the EHR because that's what you actually need if you're going to translate into clinical practice.
Thank you. We have a question about bias. How can we address the compounding bias that occurs, for example, when devices like pulse oximeters provide less accurate readings for patients with darker skin? What steps can healthcare systems take to prevent inaccuracies from shaping clinical decisions or being built into data-driven tools and clinical algorithms?
Yeah, so it's a very tough question. I will start by saying people say to me, you know, how are you going to mitigate bias in these algorithms? And my answer is we can't have a conversation about mitigating bias in these data-driven interventions or algorithms if we don't first measure it, right? You can't solve for a problem you don't measure. So I feel like right now we have to build these systems to have sort of checkpoints. Some people call it sort of algorithmovigilance, to be able to identify potential sources of biases and sort of understand their impact on performance and outcomes, and give us sort of the early warning signs where sort of these algorithms and digital interventions are performing in ways that are unexpected. And there's no doubt about it, just like any novel diagnostic or therapeutic, there will be unintended consequences, right? I'm not going to editorialize about some of the decisions maybe that go into, the design of some of these devices that clearly exhibit biases in terms of outcomes because of things like skin tone. One might guess that you could have anticipated that and designed for that, but let's just assume that that was not the case. I think you have to start with, are you constantly measuring and evaluating? So one of the things we talk a lot about here at WashU is sort of building what we call our sort of AI command center, which is really how do we monitor in real time the performance of all these different digital interventions and find sort of behaviors that are unexpected or outliers, and then investigate them so we can find these sources of bias. And then we need to measure that and make sure we have the data sets to be able to assess. And then frankly, we need to intervene and modify. So that goes back to that continuous optimization process. And by the way, if we get something that doesn't work, then we should change it, right? We shouldn't just deploy a model and walk away and hope for the best. And so I guess that was sort of a really long-winded way of saying we need to start with getting really good at measuring and identifying bias as a precursor to mitigating bias. And then I didn't say it, but we have to educate, and we're doing this right now. We've embedded this in our medical school curriculum. We need to educate our providers to be critical consumers of these tools and recognizing sort of those sources of bias in their own clinical practice so that they understand what to look for. So hopefully they can overcome at a sort of human level some of the potential biases that the digital interventions might introduce.
We have several comments about how people enjoyed the extraordinary presentation. There's two questions that I'm going to merge because they touch upon ethics and oversight. When you were talking earlier about algorithms and the physician versus AI alone, a question came up, what can or should be the role of FDA in this space? And then related to that, another attendee is asking, what do you think is the most critical ethical question to ask about the clinical use of AI?
Yeah. Okay. So for starters, it's a very tough time to answer questions about FDA because unfortunately, a lot of our colleagues who were responsible for building sort of the FDA's framework for AI are no longer employed by the FDA. But setting that aside for a moment, I would say for starters, the most important priority for us has to be any AI related tools that are closed loop, right? Where there are not humans in sort of the decision making cycle for all the reasons we just actually touched on. And that's a space where I think regulating AI in a way that's not dissimilar from medical devices makes sense. With the caveat that so far, many of the frameworks that have been proposed by the FDA try to impose sort of a medical device regulatory paradigm that does not account for the dynamic nature of these AI tools. So for example, AI algorithms, if we're using deep learning, learn from the data and change over time. So saying that we're going to lock in a version of the algorithm and it's going to be fixed in time and space, and then we're going to sort of certify that actually breaks all of these sort of features that make the AI useful. So I would say closed loop systems need to be the priority of the sort of regulatory frameworks that we build through FDA, and we need new paradigms for regulating them. For open loop systems, I have mixed feelings about that. Like if I am building a tool that is going to be used alongside other tools by our clinicians or patients or both, I think we need to be very careful not to stifle innovation there by over-regulating those, right? Because if we are still leaving humans in the decision-making seat, then we need to make sure that we allow those tools to evolve. But what I do think is some sort of certification process that's not quite as aggressive as sort of, the way we address, say, novel devices may be appropriate to sort of give what I often describe as like almost an underwriter laboratory seal of approval. And this is where sort of, if you're familiar, the whole conversation around assurance labs gets very interesting. And then with regards to the ethical principles, I would actually tell you, in addition to all the conversations we had about bias here, which I think is absolutely essential, that we need to measure and understand and how that impacts quality, safety, outcomes, and equity of care, there's also a whole nother body of sort of ethical dilemmas, which I've been introduced to through my work with NAM, which has to do with the environmental impact of these technologies. And we often lose sight of this. But, you know, when you have, for example, large language models that cost billions of dollars in the future to train, that's just a proxy for sort of both energy and other sort of consumable consumption. And that's a scary space, right? Is sort of the benefit of these technologies worth the environmental, human, and fiscal costs? And could those be deployed somewhere more effectively? So like we have individual level ethical dilemmas around biases, outcomes, quality, and safety of care. And then we have global ethical dilemmas around sort of the fundamental impact of these technologies, which are not benign.
Unfortunately, we're running out of time. I know there's still lots of great and thought-provoking questions in the Q&A, and maybe you could email Dr. Payne directly.
Yep.
We will make sure to have the presentation uploaded on our YouTube channel, I think within the next few days. I want to remind folks that our next webinar is on Thursday, May 8th, with Dr. Nick Odom from the University of Alabama, talking about predicting clinical outcomes in advanced cancer family caregivers and their care recipients using digital phenotyping. And with that, Philip, thank you again for this wonderful talk, and thank you all for attending.